Aloha and good morning, everyone. I am so grateful to be here, at least temporarily, COVID-free and amongst my colleagues. I know it's not quite 100% of where we want to be, but we'll make the rest up with virtually. Let me organize myself just quickly. Where does this point? Oh, there we go. All right. So, I'm really grateful that you've been able to come out and join us. As it's been mentioned, it's been over a decade that we first gathered to address this question about provider workforce in Hawaii. The original premise was in 2010, as it was spoken about, and it was a collaborative between JABSM and Drs. Kelly Withy, as well as David Sakamoto, who put together a position paper. And the position paper was to look at the data, as well as make an assessment and somewhat of a plan of what we should do. They tasked themselves at putting together a database of all the non-military physicians practicing in the state. They put together a model to look at the demand and the supply that was needed for our state. And then they began to predict over the next decade, and back then a decade would be 2020, of what would be the shortfall. The findings at that time was a prediction that we would be short about 1,600 providers in the community. That put us at a 20% shortfall at 2010 and an exacerbation of it over the next 10 years. From this data, we had our first, and again, we've referenced it, our very first annual workforce summit. Only 144 people participated. Today, I believe, Kelly, it's 900 individuals that are participating, including virtually. At the time, it was the first that they were looking at this data, and there was an assessment and a review and a prioritization of what we should focus on. And what you have before you on the screen were the top 10 asks. Administrative simplification, a questioning whether or not we were looking at the correct model to move forward in the next decade. Integration of the community workforce of recruitment and retention. The bane of electronic health records. Expansion of the pipelines. Increase of the net physician income. Targeted training. Usage of non-physician providers. A pay differential for neighbor islands and rural areas. And finally, tort reform. Despite all of this that you're seeing and the conversations that we've had over the last decade, the categories are falling, the categories of solutions fall into basically three pillars. Increasing the pipeline, expanding the workforce, and retention. I'm sorry, I'm so sloppy with this. So in 2022, remember there was a prediction of 1,600 physicians short. We find ourselves short of about 900 physicians. And as you leave the zip code of 96813, it's exacerbated. It is felt in a way that it is a crisis. Where we are now is, again, focusing on the pillars, the general groups of strategies. We have the Department of Education Career Progress, the Glide Paths. University of Hawaii, both Manoa and West Oahu are involved with allied training programs. Resilient Hawaii. Each of our major health systems, Queens and HPH, have summer internship programs. AHEC has done incredible to serve as a bastion of resources to get our young involved in entering healthcare. It was mentioned earlier, but the Native Hawaiian scholarships are now funding up to 1/3 of the JAPSOM graduates. And even our practicing clinicians are getting involved by embracing the idea of taking on a lot of the young students that are in the community that are just thinking of going into healthcare and having them work within their offices. With regard to expanding the workforce, we have many, many programs going on, some of them overlapping. We have the University of Washington with the new PA program in Kona, Waianae Coast Comprehensive partnering with Arizona State, the Honolulu Nursing Residency Program, scholarships again that we mentioned that will fund Dr. Jairus Hedges' goal to make it 100% of the JAPSOM class, and expanding interprofessional healthcare training that includes not just MD, DOs, but PAs and nurse practitioners. The state loan reimbursement has expanded exponentially in the last 10 years. There's preceptor tax credit programs, as well as what has changed, recruiter collaborations that I think Josh alluded to, not just trying to recruit the individuals that trained here, that were born here, that love to be in Hawaii, but those that have left and are thinking of coming back. We have the Healthcare Job Board that is promoted by AHEC and the Hawaii Interprofessional Institute. This pillar, the third pillar, is something that I think is probably going to be a focus for all of us as we decide where shall we place our greatest efforts and where should we place our greatest collaboration, is retention. Because in the end, it doesn't matter how many we make and grow if we cannot keep them here. How do we increase not just the number of professionals, whether it be physicians, but how do we address that this continually is the place that you want to practice, that is financially sustainable, and maintains the joy of practicing medicine. Listed there are a few more projects that are in progress, including learning communities, some exemptions for healthcare, such as the general excise tax, planning for the Academic Health Center at Waipahu High School, the VA Interprofessional Education Center, as well as, and this is an interesting one that I will show, will be part of a panel later on at 1:30 today, is planning for dedicated student housing and vehicles for rotations as they go into the neighbor island, and then taking that concept even a step further to address housing for a lot of our healthcare providers. And then it brings us to our panel itself and why we're here. I would like to invite up a group that we've assembled, and it is supposed to be a cut across both our healthcare leaders as well as those who are still very much practicing in the trenches. We have with us, and Kelly, how are we doing virtually? So is he on? Okay. I'm sorry? I assume he's in the audience. Is he all here? And I'm gonna rattle off our panelists in alphabetical order. Yes, and they can come on up, you know. Like I said, we're not 100%. So virtually, we have Les Chun, Dr. Les Chun, who is an internist by training. He's a local physician and a healthcare leader. He is the CEO of Hawaii Pacific Medical Group, which is a subsidiary of Hawaii Pacific Health. We have Dr. Greigh Hirata, who is a local perinatologist. He is also an independent practitioner who formed the Fetal Diagnostic Institute of the Pacific, and he is also president of Hawaii Independent Physician Association, which is the largest inter-island physician organization in Hawaii. Also joining us is Dr. Natasha Parekh, who is a practicing internist at Empower Health, a collaboration between HMSA and Queens Medical Center. In her free time, as well as raising a very young family, she's also the Chief Medical Officer for the MSSP ACO. She's the executive director for the Queens Akoakoa Physician Organization, as well as the medical director for the Primary Care Provider Enterprise. We also have with us Dr. Stephanie Park, another trained internist who is presently serving as the Chief Medical Officer for HMSA. And I tease her a little bit because that in itself, you know, being a physician leader is a direction that I think some of us are choosing to go in to try to make a difference in healthcare beyond patient care. And there's a bit of pride of taking on this very difficult path, but I'm glad that she can join us today. And then there's Dr. Melanie Payanal, who is a family practitioner by training. She is, in 2015, she opened up a family practice, a private practice, where she is in solo model. And she also has a young family with beautiful sons. And I believe that her pride and joy at this point is not just her professional successes, but her success of raising a son who brought Hawaii to the 2022 Little League World Championship. And last, but in no way least, we have James Winkler. James Winkler is a physician assistant by training, and he owns a private practice in Kauai. He serves as the president and CEO of Kauai Community Health Alliance, as well as both a medical provider and I would say owner and medical director of Hale Medicine and Urgent Care. And welcome everyone. Are we able to see Les at all? Or are we just going to hear him? I'll find out soon. Part of this is our panel, and the format that we're going to be using today, just so that we're all comfortable, it's going to be case-based. And we're going to go, we think we're going to be able to get through 2 cases, maybe a third. And we're going to use the cases to illustrate scenarios and talk about the issues and the solutions. The panel, in all their expertise, is going to help us decide what they think should be the top priorities, the solutions that we should focus in on. You as the audience are allowed to participate, and this QR code that is available, I believe, in your packet, as well as in the back of your the summit handout that you have, has a list of all the solutions. Your task is to choose the top 5, and you don't have to do this immediately. You can do it as the course of the discussion unfolds, but we appreciate your participation. So let's get to the case. So case number 1 is a Dr. Wong. She's a 35-year-old internist. She's a local girl. She attended Mililani High School. She went to UH Manoa for undergrad. But with regard to medical school and residency, she went away. She's funded most of her education with student loans. And she met her husband, a nurse, while she was doing residency at OHSU. After residency, she ended up joining a private practice in Portland, Oregon. And after about 10 years, what she has to show for it is a husband and 2 young children. But like many people, she's missing Hawaii. Her parents are aging, and they make a decision that they want to return back. They'd like to raise their family here. And she takes on a position at one of the larger health systems in primary care practice. Interesting fact, she is the only person in this private practice, private practice, a healthcare system practice that's less than 60 years old. In terms of living, you know, they're trying to buy a house. Right now they're living with her parents. It's a little cramped. You know, it was fun at first, but it's getting a little bit tiresome. And this year alone, they've put in 10 bids, unsuccessful bids, that for a house. Let me make sure. Is it on the second slide? Sorry. Okay. As many, she's made the decision that she's going to place her children in private school. But as luck will have it, they didn't get into the same school. So she's got separate drop-offs. And then they're doing exactly what she wanted them to do. They're thriving academically and they're on sports teams. Sports teams means someone's got to drop them off because it's not like in high school. This is elementary school. Someone's got to drop them off. Someone's got to pick them up. And she's finding that on a regular basis, she's got to call out her sibling favor to get them to be dropped off and picked up, because almost always she cannot get out of clinic. The clinic, while it is a large health system, it's extremely inefficient. The EHR makes a lot of tasks very cumbersome. The stress that the clinicians feel is also what the MAs feel. So a lot of calls and a lot of messages often end up at the end of the day and need to be followed up. So again, getting out of clinic late. She thinks back to the time when she was in Portland, and the work week was a lot more flexible. For starters, she did not have to work a full week. She could work a 4-day week or a flexible week. But now living in Hawaii and trying to get in one of those bids to be successful, she needs to work full time. Her and her husband are starting to think about their life back in Portland and what they had there and what they've given up as a result of coming back to Hawaii. And she's really starting to question whether or not it would work out. So here we have our problem. And I'm going to give someone an opportunity. Just one housekeeping thing. So can we see? Yeah. There's no way to split the screens. No, sorry. So you get to either see less or you get to see the solutions. So I'm going to have you memorize the solutions. Let me just read them off to you really quickly. And then we're going to put Les on the screen so that he's at least participating. So while you may have opinions, and the panelists are also going to come opinions, up here, we're identifying some major issues from the case as housing availability, loan burden, complexities with managing a family, lack of connectivity and support, compensation not adjusted for cost of living, and the clinical insufficiencies, basically administrative burden. Let me pick on you a little bit, Les. You've been following along?
Thanks, Dr. Salle.
Hey,
good morning.
Do you want to lead us off a little bit with maybe kind of a first issue and solution?
Sure. My apologies to all of you that I'm not physically present today. I'm recovering from my first bout of COVID and just wanted to keep everyone safe. You know, Dr. Wong's story, unfortunately, is not too uncommon and highlights many of the struggles we have in Hawaii. As Dr. Salle eloquently said, you know, we all know there's no one magic bullet, unfortunately, to solve our workforce issues overnight. Our solution set has to be multifaceted and include a wide variety of complementary programs. You know, as Dr. Salle said, you know, there's at least 3 buckets of work: securing our pipeline, ensuring that we do everything we can to support those in practice already, and then retention. And perhaps a 4th bucket, and I don't want to overly complicate her case already, but I wanted to put something out there that we can extend, best utilize our existing base of physicians to overcome the limited number of providers we already have in the state. And so if I may, I'd like to focus on that and come around to Dr. Wong. But I think, you know, we can't hire, you know, the 900 providers we're short overnight. You know, as Dr. Withey's research also shows that primary care is our #1 and most dramatic place of need. And certainly Dr. Wong fits into that category. Losing her to the mainland is tough, and since we already don't have enough, and in fact, nationwide, we don't have enough primary care doctors. That competition with, you know, health systems nationwide, as well as, you know, the tough economics of working and living in Hawaii, make it all the tougher. But what I wanted to put out there, and I know many of the panelists in preparation of this, we talked about team-based care as being one of the solutions. As some of you know, having social workers, pharmacists, dietitians, community health workers, and many others as part of that primary care team can really help support the physician and help support our patients. And in some cases, increase the panel size for physicians up to double. Patients seem to like it. Actually, the evidence shows they like it because there's a large resource of people beyond the physician they can rely on. And then I think existing physicians can focus on what we've been trained to do, and offload some of the other tasks to others who can do it more effectively. And then and sorry, Dr. Salle, for going on for a little bit, but I think it's not just hiring the teams, it's also working on those pipelines, and then also the training that we have of physicians and all those social workers, the pharmacists, dietitians, community health workers, to be able to, in their training, work as teams, to be able to help provide that new generation and support the existing generations of providers to really meet that need in a more proximate manner.
No, thank you, Les. So team-based models for your choice.
Definitely.
Who would like to be next? Go ahead, James.
Hi. So I'm here sort of representing rural health in the sense that I run a practice on Kauai, which is a rural neighbor island, and I'm in a rural part of that rural neighbor island. Just to correct something, it's not a private practice. We're a nonprofit 501c3.
I apologize.
Oh, no, that's fine. I just wanted to clarify. I speak with the heart of a provider because I've been a provider for 30 years, but I'm mostly speaking as the CEO now because I'm so intimately involved in the finances of trying to survive. To jump to the punchline, our facility, just like other facilities in rural communities, are on the verge of closing. We've lost 25% of private practices in Hawaii in the last 2 years. I haven't taken a paycheck in 4 months. We have physicians working for $70 an hour, which for those of you that know physician salaries, that's about a third of a physician's salary. We are an efficiently run organization. We've been here for 25 years. We have urgent care, we have a full family practice, we have a physical therapy department with 4 therapists, we have behavioral medicine. We serve a number of communities and we are about to close. In response to the idea of working as a, how is it phrased? A collaborative with other disciplines, social workers, etc. This is not a solution that will work on neighbor islands. We don't even have an endocrinologist. We have no outpatient neurologist. We have no palliative care medicine. We have no oncologist. We don't have a psychiatrist. Maybe
So
it's hard to work as a
right
with.
I'm going to interrupt you
Sure.
just for a second. 2 things. One, with regard to the team-based model, and again, whether or not it would work effectively where you practice. I could be wrong, and I shouldn't speak for Les. I'm assuming it's difficult for him to banter back and forth. What you're describing is a team-based model amongst clinicians, and I believe he was referring to a team-based model within the practice, meaning changing the roles that people within the office, whether it's MAs or such, would play to make the clinicians or the provider's life different or easier. Is that what you?
I mean, we're six providers, a staff of 30 altogether. I'd have to know what kind of details. I'd have to be
then
happy
the
to
flip
talk to
would
Les.
be, if that is not a good solution, what would be your chosen?
Well,
what would you choose, and what would you promote as that should be a priority to actually help practices such as yours?
Well, I can tell you from the perspective of practicing on a rural part of a rural island and not being able to make payroll, it's all about income. It's all about basically our revenue stream is so low because our reimbursement is so low. So none of our providers are still paying off student loans. They've all been in practice 10 or more years. I mean, these are all amazingly wonderful ideas. And it has to be it's a complex problem, and it has to be a multifaceted approach. But if you're asking me what is the one trim tab, the one pressure point, it's low reimbursement. Medicare reimbursement is the lowest in the country in Hawaii. We're literally ranked number 50. Some of you may not be aware that Medicare does not pay the same to every physician all over the United States. We in Hawaii get less for the same procedure as that being done in rural Alabama. And Alaska gets 50% more than we do for doing the exact same procedure. So we are the lowest reimbursed in the country with the highest cost of business. And private insurers, commercial insurers, Stephanie, block your ears, but they tie their reimbursement bar to Medicare. They pay, the average is Medicare plus 30% in the state of Hawaii. HMSA actually pays us below Medicare rates on our last analysis. Medicaid Quest is half of that. So all of this just boils down to low reimbursement. And while all these,
so maybe let's take, maybe
Oh.
let's take that point a little bit. Did you want to go for it, Les?
Oh, just if I may, just maybe beyond just reimbursements, it's more payment model changes. And I know HMSA has made a huge progress on that. And I think other insurers can follow to really support and promote the team-based care. And I hear you, Jim, the rural areas are tough to hire. But I think, as Dr. Salle was saying, hiring beyond just physicians and making a broader team, and even using telemedicine to rely on other sources of that talent.
So maybe let me ask the panel before we choose, say, another a priority, comments about the reimbursement solution. Dr. Parekh. Poor thing is on the hot seat here.
Is this on? Can you hear me?
Yeah, it's on.
Okay, great. So thanks for this opportunity to participate on this panel. I really do appreciate being part of the conversation about being part of the solution for this issue that I think everyone is acutely feeling now, especially with this post-pandemic recovery period where inflation is affecting everyone's practices. Burnout is a real thing that everyone is struggling with, and retention of their staff. Oh, can't hear you? Okay, is that better?
Yes.
Oh, great.
Maybe start
Again?
maybe about a third of the way through.
Okay. So can you hear me now? It's better? All right. So thanks for this opportunity to be part of the solution. I think everyone here has been through a lot over the past couple of years. And as we emerge from the pandemic, we're feeling a lot of things like the inflation and burnout, to be frank, from all that has happened over the past couple of years. I hear from you guys about retaining your staff is costing a whole lot more. And yet, with the way that reimbursements have been structured, it's really hard to afford what you need to continue to practice and deliver the care that you'd like to. So in terms of increasing reimbursements, this is something that I think a lot about, and I wonder how we can partner together to figure out how we can increase the pie for everyone to have a larger portion for their share. And in preparation for this panel today, I thought about ways that we that everyone could help increase that pie. And so from CMS, I think we all learned that it's really hard to control the federal government, and what they reimburse us for the care that is provided is what we're able to pass along. There's just no more. So how do we increase that pie? There's a couple of ways. So we are eligible for quality payments, and ways that we can increase that CMS pie are to help with some of the risk adjustment activities that we have. So, those troublesome requests that we send out to, please send your chart in, please code how sick your patients are, so we can get the right amount of payment to help you take care of those really sick members. That's what we're trying to do when we're asking for charts. We're trying to get appropriate payment from the government entities to help manage your sick patients. The other thing that we need your help with is with CAPS scores. So these are the patient satisfaction scores that go out. The results of those scores directly affect the payments that come back to us. And with all that has happened over the past couple of years, some of those payments are anticipated to actually fall, disappointingly. So what can we do? Please do your best. I know you're running at 100 miles an hour every day, but when we ask you for those charts, please please do your best to help us with that, because we're trying to increase payments to you guys. And those patient satisfaction scores, they really do affect the payments. So those are two things that you can help us with to actually increase these government-based payments.
Are there some thoughts about these various areas that we all consider just a pain in the butt and purposely don't do just to spite you, make it either more efficient, less of administrative burden, something that it's very easy to do. The second would be to follow up with maybe James's point. Is there a way to have a rural pay differential for the increased rate? I'm putting you on the spot a little bit, but I meant what is possible to at least talk about and to.
Absolutely. So let's have a conversation about this. We can work together on what makes sense, because, as we think about the healthcare ecosystem as a whole, there are things that we can definitely try to rebalance, because it is a very kind of tenuous balancing act that we have for this. But in terms of reducing administrative burden, this is another topic near and dear to my heart. When I pivoted from clinical medicine into this administrative medicine role about 10 years ago, I was thrust into this world of utilization management, which I'm sure is the bane of everyone's existence here. And I've spent a lot of time thinking about, how do we return, what are we doing? How can we return the joy of the practice of medicine to everybody? And is the juice worth the squeeze? Do these things really make sense? And so I spent a lot of time thinking about how can we change what we're doing going forward? How can we provide more information to everyone so they can make the right choices? And one recommendation that I can make at this time, in terms of reducing it, well, actually I can think of a couple. Reducing your administrative burden is to, if you haven't heard of the American Board of Internal Medicine, choosing wisely, what that is it's recommendations from various specialties on what kind of tests and procedures and treatments to avoid, because they're not evidence-based. Please don't do those. Stop requesting pre-cert on things that don't require pre-cert. That just kind of really clogs up the system. And one other thing that I'd like to share that we're working on to try and reduce some of the heartache that comes around prescribing the right medication, because gosh, there sure are a lot of formularies out there, and how can you possibly know which one is the one that you need to use for the patient in front of you? You know, we're trying to leverage technology to get that information in front of you in real time, so you have the information that you need to make the best decision for your patient that will be covered when they're sitting in front of you, as opposed to having to field that call when you're trying to see the 30 other patients that you're trying to take care of
No,
that day.
thank you. Thank you. Well, why don't we keep going? And Natasha,
Yeah, sure. Okay,
Johnny, yeah.
sounds good. So full transparency, this case is actually based on a friend of mine. I changed her name and I changed some details, but I actually talked to her this morning and I shared with her all the solutions that we outlined and asked her, because she actually, so I'll give you the answer. She's leaving early next year. And I asked her, of these solutions or any solutions, what are the things that you think would have changed your mind? And the first thing she said is, look, money talks for sure. I think the adjustment around cost of living versus salary is not complete with a lot of job opportunities here. And so she said it would be nice to get paid more. The place that she ended up choosing to go to, they're actually providing really substantial mortgage assistance support, where her hospital system is actually giving her $600,000 interest-free loan to buy a house. She has to pay them back over the course of 5 years, but it's interest-free. So that was, I think that's powerful. That's wonderful that she was able to find an opportunity where there is a system that's really kind of supporting her financially. But what she did tell me is, she said, I wouldn't have looked if it wasn't for how burnt out I am from the administrative burden. Clinic inefficiency plus administrative burdens have caused herself, as well as a lot of providers in her practice, to just say, I think I'm done right now. Exploring that a little bit further, because I agree with Les, the team-based model of care, when you have a team, is wonderful. I think the concept of people working at the highest scope of their training, everybody working together, trying to think through, based on your training as a physician, do I need to do all of this paperwork? And ooh, sounds like an elephant. Do I need to do all of this paperwork and all of these phone calls, or can I help delegate this to some of my team members? I think is a wonderful concept. And when it works really well, and it makes everybody more efficient. The challenge that I don't think I outlined on the case, so I apologize, is that her clinic is about 3 medical assistants down. Most clinics on our system are about, I think on average, 2 medical assistants down. And so when you're really kind of relying on the team-based model of care for the joy of, to really kind of emphasize and capitalize on the joy of medicine, you need a team that has stayed, and you need a team that has been able to be retained. And I think, and I don't think this is unique with our system, I think across the state, we have a lot of shortages, not just of physicians, but of other healthcare staff to be a part of that team-based model. I'll give you an example, and I know one of our primary care doctors is here, so she knows as well. We've had a few medical assistants leave over the last year for non-healthcare based jobs. When asked why, because they were wonderful medical assistants, they said, look, I got a job opportunity that's higher paid and lower stress. So why not? And so when I think about that, and this is somebody who was excellent at her job, and somebody who really helped us with the team-based model of care, well, we lost her to non-healthcare based jobs. So I agree, the team-based model of care is wonderful, and when it works, it works. It's just hard because of kind of the turnover right now that we're seeing in healthcare, not just in the physician workforce, but in other healthcare workers as well.
So let me challenge you.
Okay.
Let me challenge you while you're speaking.
Yes.
Let me challenge you while you're speaking. So then what's your number one choice? Because the theme today is, we know there is a problem.
Yeah.
What are the solutions we're willing to lean into?
Right. Can I have one more thing and then I'll get to the solutions? So I don't know if any of you saw the Journal of General Internal Medicine article from July 1st around kind of the burden and the number of hours it takes to actually take good care of your patients. So this article on July 1st, I recommend you reading it, basically said that for a primary care provider, we would need 27 hours per day to see an average number of patients on our panel to provide good quality of care. That's 14 hours of preventive care, so counseling around screenings and prevention, 7 hours for chronic disease management, 2 hours for acute care, and about 3 to 4 hours of administrative work. What the authors then go on to say is that in a strong team-based model of care environment, you could reduce that number of hours a day to 9 hours, a lot more doable. And that's kind of where we should be working, right? So I think in terms of solutions, part of it is investing, I think, in not just our physician workforce, but also our teams, ensuring that for especially our staff at clinics and hospital systems, that there's reason to stay. Because right now there are non-healthcare domains that are taking our employees. So what are ways that we can think about retention strategies for our medical assistants, for our staff members, whether it be kind of retention bonuses or upward mobility. We have some medical assistants who are excellent who say, I don't really have a place to go above this right now.
Right.
And so I think upward mobility, retention bonuses for staff, and then also the administrative burden piece. And so, Steph, I appreciate you sharing kind of that's been a big bane for you, of your existence as well in terms of as an insurer. If we could kind of think through solutions that don't add burden, because I think payment transformation is a wonderful program in concept. I think it's added a lot of administrative burden to practices. Practices are having to hire on average 1 or 2 more people per practice to succeed in it. Sorry, that was a lot.
So we're hearing team-based model, decrease administrative care. I'm still throwing in that rural differential, as well as adjusting income for physician or provider income for cost of living. We're going to try to go on to the next case, but either Melanie or Dr. Hirata, is there anything you want to jump on?
Excuse me, I wanted to say that our physicians in Hawaii don't have that problem.
Yeah.
No, I'm just joking. The problem that is illustrated is exactly in private practice.
Yes.
Except that we don't have the infrastructure to do the team-based model. So in our model, what we do is we provide the Medical Service Association, the medical service organization for our physician members so that they can be comparable to what a healthcare system might have. But I think
But this is a healthcare system physician that's being lost.
Correct.
So it's interesting to see it occur even with the entity that has resources.
Right. That's true. I mean, that's a good point. So there's other things, but I think the interesting thing in your slide with highlighted the 10 priorities, are they pretty much all the same?
Yes.
From 2010 to 2012 at 22. And I think the number one theme is finances. So it's either increasing reimbursement or you're decreasing cost. And reducing administrative burden is no different than increasing reimbursement in terms of the bottom line. Besides that, the forgiveness of the general excise tax is basically like giving a 4% raise to everybody. So, I mean, there's a lot of ways you can do it. We chose to stay independent for a very good reason. We are independent because we feel that that's the best way you can provide medical care. And about over half of our physicians in the state are still independent. And we struggle every day with trying to stay independent, but it is difficult unless you, I don't want to say organize, but unless you participate in the healthcare milieu, because if you don't participate, we're going to be all lost.
Agree. What I'm going to do, guys, I'm going to actually go to the next case, and I'm going to start with you, Melanie, in the next case, and feel free to combine the two. So your comments will not be lost, but just to move on. So we're looking, this one is Dr. Han. He's 65 years old, so he's on Medicare eligible at this point. He is a specialist, so not a PCP. Again, local boy, St. Louis alum, did undergraduate as well as medical school and training away. So he was the one that we would have had to figure out that he still exists and to lure him back to Hawaii. But he did come back. He opened up a practice, and after 14 years, I'm sorry, he did come back, and he came back first in the capacity of being a hospital employee. And for various reasons, he decided that he had had enough of that model and he wanted to open up his own private practice. Lo and behold, we're looking at a successful practice that has existed for 18 years. There are other physicians in his practice. There's 24 nurses, genetic counselors, sonographers, medical assistants. I mean, this is a thriving a practice in and itself. But he is struggling with what's next. The days of people practicing until they literally get a condo in Arcadia are done. I think COVID drove home a sentiment that maybe you're not going to do this forever. That retirement is something that you'd like to plan out, and maybe you'd like to have some time to enjoy a life beyond medicine. I'm not saying that's for everyone, but I'm going to maybe craft that for this person itself. So what we have here is another scenario. And again, our issues and solutions. And while this may be a little bit, being a specialist, slightly different than your scenario, Melanie, let's start with you. You have to put it right to your mouth. No, all the way. Maybe give her this one.
Thank you. Okay, can
There you go.
everyone hear me? All right. I hope to survive this career path of medicine until 65 years of age. And I also hope I somehow make it to a room in Arcadia when I retire, if I don't croak over. In the meantime of maintaining a private practice. I really have a lot of sentiment to the first case. Hopefully we'll get to the next case if time permits, but I am a private practice physician and I'm a solo private practice. I started my solo private practice straight out of residency, which nobody does that these days, and I probably would not recommend it. But it's difficult to survive, and the bottom line is the biggest problem is the finances, right? When you work for a large healthcare center, you can have a multidisciplinary team. It's wonderful. Everybody has administrative assistants who are maintaining the choreo and HMSA, who are going to send in the medical records. That's wonderful. But when you're a private practice physician like myself with one solo employee, that administration burden becomes your responsibility in the middle of the night, and you sacrifice whatever hours you have between patients, between your family to get those all done. And really the bottom line is, how are we going to make it financially feasible for our generation and the next to continue to do medicine here in the state of Hawaii? I choose to stay here in Hawaii because I have 3 boys. I was born and raised here. I went to Kamehameha. I grew up in Makaha. Many of us on the west side don't make it this far. And I sort of have a debt to pay, right? When you grow up here, you have a debt to take care of your people, and not just your Native Hawaiian communities, but your people of all ethnicities here in Hawaii, because this is your place you call home. And despite how much you struggle every single day and how much you think you want to give up, every single day you wake up and you still make it. Somehow, even with just 2 or 3 hours, you make it to the next day because you have a desire. This is what you went to medical school for. This is why you chose primary care. And this is why you keep struggling. But the bottom line is, even if you have that passion in your heart, you still have to make the bills, pay your staff. You've got to make your mortgage. And how that is going to come into fruition in the next 10 years, how are we going to survive? It does come down to the bottom line of, we need larger reimbursements. That's what it is. I don't know what the solution is. I think that across the board, if all lines of, payers would pay us even just 10% more, I think we would have a little more cushion to feel comfortable that we can make the clinic survive. They say at year number 7, You should know whether your business, whether it's in medicine, a restaurant business, by year number 7, you'll know whether that business will survive or not. And through the pandemic, it's been very rough, I would say, to keep it going. I hear you. Patient satisfaction, yes, very important as a factor for how you're going to reimburse me. That's wonderful. But tell me, through the pandemic, when you have about 25 people calling with symptoms of COVID, but you're working 7 to 7 p.m. seeing patients, that's not even the administrative burden. How do you maintain seeing every single one of them that calls in for a same-day appointment and have that satisfaction at 90% or above? That's hard. And that is a reality. I don't know. I don't have a solution for that. And although the pandemic is dwindling down and we're seeing patients in clinic now, it's the emotional burden of COVID. People losing their jobs, not making money, social isolation. And I hate to say it, you can't address that in 15 minutes. You can't even address that in 20. And as much as you want to help them, you have to prioritize. You make another appointment for them. You have them come back. That's hard. And an interdisciplinary team, absolutely. I think medicine should be that way. Hospice is like that, where we have interdisciplinary teams, and we should have that in all of medicine, including primary care, where we have a pharmacist, a social worker, a case manager for complex care. And I echo this all the time. Thank God I have my physician organization that helps me with a lot of it. And thank God we have those people that help us to survive in private practice. But the bottom line is, I still got to pay my bills. The reimbursement has to be there in order for me to survive. And that's just the bottom line.
So I'm hearing reimbursement float to the top, administrative burden, team-based care, and I keep throwing in the rural differential. Okay.
I just want to make one comment that something Greg said and that you've just pointed out to. Some people might think, well, then maybe it doesn't work to have private practice. Maybe it doesn't work to have small clinics. Like we have the same issue as you do with 6 providers. So 1 provider, 6 providers. And as Greg said, 50% of our, did I get that right, of our workforce, of our physician workforce is in private practice. It's not only great medicine to have private practice, it's essential because on rural islands and on rural parts of Oahu, you can't build a Queens Medical Center on the North Shore of Kauai or Big Island. Like, so we have to have these small
private
medical
practice,
groups.
and we have to be able to support them. Absolutely. Absolutely.
James, I echo that. I think employment, even coming from one of the large systems, is not the answer for our state. It needs to be a combination of private practice as well as employed physicians. I think without that sort of chimeric mix, we're not going to be able to meet the demands and the needs of our state.
So let me throw out a generic question to Les, to Natasha, and then Greigh, meaning healthcare system, large physician organization.
Can I go
So
first?
what, yeah, and then you're going to be first. And, you know, what does that mean? Are we speaking about that this is impossible unless there's a formal collaboration between the entities, because you cannot have just an employee-based model, or you cannot just have a private practice model, and reimbursement as it stands right now is not supporting the practices, particularly the ones
If I
that
can
outside.
go first, just to clarify, that physician is only 64, it's not 65.
It's not based on anyone we know.
Not based on it. Well, you know what? I called my own number because I didn't want to embarrass anybody else. But I think as a specialist, my issues are not too different than a lot of independent physicians in the community. I wanted to go back a little bit because it's been a journey for me. I'm just a, poor country doctor trying to make a way. And I had to learn all this administrative stuff. I had to learn all the acronyms, so I can spit out the acronyms forever now because the acronyms are so important in healthcare, especially administrative healthcare. But we have had the privilege in our IPA of being pretty much on the front. And, you know, Dr. Tenn-Salle was my predecessor at the IPA, so she knows exactly what we're talking about. And we've been guided by a strategist, a physician who has been through HMSA and been through the whole thing. But I think we were finally convinced that the path forward for us as physicians would be to take more of an economic risk with payers. And our solution, which hopefully will come to fruition in the next few months, is that we develop a risk-based entity that can partner with another organization that has more resources, not necessarily with or without the hospital. But we, at that point, as a physician, a risk-based entity can go to the payers and say, we want to take risk for this group of patients, not unlike what Queens does and not unlike what HPH does. And go one step further, we're willing to take downside risk because you get more upside risk if you take more, or willing to take more downside risk. Now this is, you know, radical. I mean, this is very different than most organizations in the state, but I don't think as physician organizations, we're going to have any control until we have control of the dollars and where it's spent and how it's allocated. And, you know, taking that burden away from physicians so that they can get back into what they do best, which is practice medicine.
No, excellent, well said. So I mean, in the vein then of reimbursement, unless the insurers are going to increase the reimbursement to the providers, one suggestion was to be more efficient. And now what you're suggesting is a third pathway in which there is risk. Natasha, you want to comment on that?
So I wanted to comment, and I wanted to agree with something that Les said, which is the answer is not employment for everybody. So I'm the chief medical officer for our PO. 50% of our, even though we're Queens, 50% of our PO is actually private practice, community-based providers. And so our responsibility is to advocate and to support all of our providers, including employed and non-employed. And so, so agreed with kind of the comment and your comment around independent private practice is necessary, especially in places that don't kind of get touched by kind of the bubbles of the big healthcare center. So totally agree. In terms of taking on risk, I agree that I think that's where I think a lot of people in healthcare believe the world is going, is all of us kind of right now we're kind of on the stepping stones to taking on more risk with the ultimate goal of kind of complete full-on risk. I think it's a little scary because full risk is scary. It's exciting if you know exactly how to succeed and you know exactly how to win in the game of risk-based models. But I think and I don't think this is unique to here. I think across the country, a lot of organizations are still trying to understand what's the magic recipe for success. How do you meaningfully improve quality and reduce costs for populations? And for a lot of organizations, Steph, you mentioned risk adjustment. It's risk adjustment because at least if you could capture how sick people are, maybe you'll win in risk adjusted costs. And I don't mean to say this is a game, but it kind of is sometimes. But yeah, agree that I think the world is going towards risk, and whether it be healthcare systems and large organizations or independent private practices taking on risk, I think that's where we're all going. I think in some ways, even when you talk to very successful organizations and risk-based contracts, you ask them, what did you do? Like, how did you win? And I've been able to talk to some and they're like, honestly, we don't really know. We think we're doing a lot of things right. We have really good care coordination. We have all these clinical pathways and initiatives. But I think it's hard to know exactly like the perfect keys to success in these models, and we're all learning.
Yeah, if you find out, let me know.
We're all learning, I guess.
If I may jump in on that, I think it goes back to some of the earlier discussions, and James, you brought up the economics of it, and Melanie, you help support that. And while I think more money is important, I think changing the models is equally, if not more important. And whether it's risk-based contracts or something else that as we evolve the healthcare system, I think it's really important. I think about it in terms of COVID. I mean, being home with COVID, it recurred to me is that early in the pandemic, right? Hawaii did extremely well, but they were low hospitalizations. Specialists didn't get to see their patients and do surgeries, etc. And economically, in some of the current payment models, that was actually adverse to us as the provider base. And you looked at the mainland and you saw places that saw tons of COVID, and they not only got the income from that, but they also got the federal subsidies, which Hawaii in the first round couldn't because our numbers were so low. And so I think, that's at the macro scale, but in terms of our practices and supporting our physicians, we need to keep looking at and keep evolving the payment system to allow for different models and to allow for, whether it's team-based care or anything else we're talking about today, because in the existing model, it just isn't sufficient at this point. And it's going to take, it's not a HMSA problem, it's not a UHA problem, it's not a Medicare problem, it's our collective problem. They just happen to have the money coming through them. But without us coming to the table, and as Steph said, having that dialogue, we can't get there.
The risk-based model, this is sort of an extra solution to consider, not part of the original list. And I like it. I do like where this conversation is going. Let me put Stephanie a little bit on the hot seat. What would you have to say as the insurer?
So alternative payment models have been something that we've been, a supporter of for a long time. Payment transformation was rolled out, and we're trying to, I guess, iterate and learn and try to evolve that program. I think for many of you, we have not evolved quickly enough, and taking more feedback from the community for how some of these programs can better serve more of your needs, especially as they've changed over the past couple of years. Now, as we learn how to practice in this new normal, balancing telehealth into the mix is another thing, that we're trying to understand what the role of telehealth is in these alternative payment models. I think being open to having the conversation about taking risk and utilizing these alternative payment models to, do things different going forward, because insanity is doing the same thing and expecting a different outcome. So I agree, let's talk about it. Let's see what the possibilities are, because there are so many opportunities. And when we lean in together to try and solution for how we, to solution for these changes that are necessary, I think we can be a more powerful voice for change.
I'm going to include an audience comment / question, and then I'll keep moving on. So again, around the risk-based model. The concern is that taking on risk, it raises administrative costs and burdens. And there's an incentive to take on the easy patients. I think we all understand that. We began this conversation even around ACOs. Is this going to be a collection of the high health literacy patients? And again, there'll be an increased disparity between who has access to healthcare and who doesn't. And that there'll be the more complex patients, the patients that require not just multiple specialists, but they're not likely to get better. They will have lifelong disease, that these risk models will exacerbate our issues here in Hawaii with regard to healthcare. Comments on that?
Comments on the risk-based model?
Well, I guess the comment is let me refocus us. So why are we here? We're, well, in a big picture, we want to make healthcare better. We're specifically here for the provider workforce, and our workforce is threatened, and that being threatened means that we cannot provide quality healthcare in a timely manner. We are going through solutions. The solutions are rising to the top. One of the solutions that sort of rose to the top was about reimbursement. And we've got the question of can providers be reimbursed at a higher rate? And the conversation is quickly going to, we're not going to reimburse you at a higher rate. So the alternative solution then is to come up with a model in which we are either more efficient or we take on risk and are able to take in income from that quote fixed pie. And the pushback to that is when you go into a risk-based model, we will increase the disparity of healthcare in the community.
Well, I would actually push back against the idea that we are not going to increase reimbursement. I don't accept that. There are a number of ways to do that. Medicaid Quest, which is by far the lowest reimbursement, and I should mention 50% of the state of Hawaii is on government insurance. That's Medicare, Medicaid Quest. So at our facility, 64% are on government insurance. The state legislature can increase reimbursement for Medicaid, just like that. And the federal government will pay 50% of that increase. So if there was enough political will for the legislature to increase Medicaid reimbursement, let's just say they increased it by $400 million a year, the federal government would be required to pay $200 million of that. So that's a legislative solution with that part of the insurance industry. Medicare, we've been working with Ashby Wolf, who's the CMO of the Western Regional Region of Medicare, and trying desperately to increase reimbursements through Medicare. Brian Schatz has been, our senator, has been very active. That's another legislative approach. The GET tax, we're like one of two states that physicians and medical facilities have to pay GET tax. That's 4.5% right off the top. That goes to the state of Hawaii. That actually is a regressive tax and hurts medical clinics. That's another legislative change. I can tell you that our facility became a nonprofit in 2008 because we were having trouble surviving then. We do not pay GET tax because we're a nonprofit. It's still not enough. So again, like this is a multifaceted thing, but those are three legislative solutions to increase reimbursement: Medicaid, GET tax, and Medicare. And with regard to commercial insurers often set their reimbursement rates based on Medicare. I'm not really understanding what you're saying, Steph, about less money from Medicare means less money from the insurance company, because insurance companies set their own bar. I mean, the average in the US is Medicare plus 30%. So obviously different insurance companies reimburse at different amounts based on the Medicare bar. I should also point out Medicare is now dropping by 8.5% its reimbursement. So as the water level goes down, all the private insurance, I mean, everything goes down. So this is just the Titanic getting ready to hit an iceberg, you know, if we haven't already struck it. So, but I think those are some practical solutions. And sorry, I didn't mean to put you on the spot. By the way,
okay.
Stephanie is awesome. She's, you know, Stephanie is a medical provider. She knows the human face of medicine, because all, you know, the poulet this morning was so meaningful to me. And then when Josh was talking about, you know, social determinants of healthcare, like everyone in this room, we're all here because of the human drama of health. Like the people with breast cancer and the people with severe crippling diseases.
No,
like,
I couldn't agree with you more.
So, you know, we're
Stephanie
all on
is
the
good
same
people.
page. It's just, how do we find our way through this, you know?
But
So
how would you
anyway.
like to respond?
Thanks, Jim. Thanks for the opportunity to talk transparently with you guys about this topic that you know, it's so close to the surface in this conversation. So, you know, when I say it's a fixed pool of money, you know, we have money coming in from the government for Medicare and Medicaid. And during the pandemic, we've had a huge shift in our payers, as you've noticed. There's a huge increase in our Quest population. There's a shrinking pool of the commercial population, and there's this. The employer groups, they come to us, and during the pandemic, a lot of them have had to defer payment for their plans because they were suffering as local businesses did during those times. So, trying to keep healthcare affordable for those commercial employer groups that we have historically leaned on to, I guess, supplement what we've paid for those government lines of business. We just don't have that flexibility as much as we historically have. So trying to figure out ways to, really improve our own internal administrative efficiency has been part of how we've looked to try and improve administrative efficiency, decrease our own internal costs. We've tried to modernize our systems so they can really be maximally efficient, and that to be honest has been a really painful internal process as we've struggled with modernization of our tech systems. But that's kind of like the long answer for, we hear you, for the increasing reimbursement. There's a real struggle with the delicate health ecosystem between, like who is paying for these things. Our employers in the community, they keep on telling us they can't afford to pay more as well. So our Quest reimbursements have gone down as well. That's another thing. And to be honest, our commercial insurance rates are at the mercy of our insurance commissioner, and they're set through 2024.
Go ahead.
I wanted to address the question initially, and maybe we'll circle back and put you back on the hot spot. But anyway, the question about cherry picking has been there forever. So you go cherry picking, basically you go for the healthiest patients that don't have much issues. You get the same PMPMs, but that's what the RAF score is for. That's why the risk adjustments are there. And hopefully your panel will change if you correctly code. Like, it helps everybody in this room if you code correctly. And it's not over coding, it's just coding correctly. Now, at our organization, we approach the issue from a little bit different perspective. We feel that if physicians are left with the decisions, they'll make the right decisions. So if you take away administrative burdens like and prior auth, they'll make the right decisions. They're going to be outliers, they're going to be overutilizers, but if you give them the responsibility for being in charge of the healthcare dollar, they'll make the right decisions. And hopefully that'll drive everything down.
Increase efficiency.
Right.
We have
So,
about,
one more thing.
go ahead, you have one more thing?
The one more thing, this is not going to put you on the spot, but to paraphrase Ronald Reagan, Dr. Park, please tear down these prior auths.
Yeah, love it. So, we have about 10 minutes, and I thought we would maybe give each of the participants maybe about 2 minutes. And here's my question to each of you. I'm going to ask this question, and first I'm going to allow the people who are practicing to answer, and then I'm going to allow those who are representing the hospital-based system, and then Stephanie, you get to end it. The question is basically to our practitioners that are up here, are you likely to be practicing in the next 3 years? And if you are considering either for financial reasons or personal reasons leaving, what would be the solution that if it were to be enacted, if it were to be successful, that you would ask for? Who would like to be first? Melanie?
Okay, that's a tough one. I will say that absolutely, you're absolutely correct in saying there is a place for us in private practice. And I think we will survive. Will I survive in 3 years? Well, I've made it to 7. And at year 5, I thought I was not going to make it. And then I pushed on and made it to 7. And I hope that I can continue to make it beyond 7 years. I've thought about it, honestly. I've actually took another board certification as a backup plan, just in case this doesn't follow through.
So what would be your one ask?
My one ask, I hate to say this and I keep having to say it and I don't know the solution, but really reimbursement. You know, if I had just even one more employee, man, that would be so amazing. I would die to have just one more employee. I think that I could be far more efficient in seeing my patients, and I wouldn't have to do so much of the administrative burdens. But that would be my one wish, just a little bit more of a reimbursement so that I could hire just one more employee. And as much as we want to do that, we got to sacrifice something else to make that happen.
I'm going to share something, so I may be crossing a line. But to just drive in, I think, you know, we think of administrative burden, we think about being up late at night. Maybe share with the audience the administrative burden, caring for patients, and where you were when your son hit his grand slam.
Oh, that's a good one. Okay, administrative burdens. Everybody knows about choreo. Everybody knows, including my 3 boys. They know what choreo is. They know, because sometimes I have to enlist them in helping me like organize the choreo. But it's the administrative burden of prior authorizations for formulary medications, non-formulary medications. You want that person on that trilogy, but it's not covered, but you need to get that prior authorization. You stay on the phone 20 minutes with Magellan for a prior auth for an MRI when you know that they need it, but you wait on that phone for 20 minutes. That's 20, 30 minutes you could be providing direct patient care. You don't have that, right? So that's administrative burden. And where was I when my son made the grand slam? Okay. My son had a grand slam in the West Regionals, and unfortunately, I worked through the entire tournament from San Bernardino to Williamsport. I took my phone, I worked my 2 jobs. When he made that grand slam, I was on the phone with a patient and missed it. So when you think about the sacrifices you make in private practice, that's the sacrifices you make because you know your job, unfortunately, sometimes becomes before your own children. And that was really devastating to see your son hit a grand slam, even with a broken arm, because his arm was broken, but not be able to see that was devastating and it hurt. And in the end, he asked me, did I see it? What is a mom going to say? You're not going to say I was on the phone, right, with your patient. You say, yeah, I saw it. And then you thank all your friends at home who are videotaping their televisions so that you could see it later that evening.
James, 2 minutes. Or Greigh, do you want to go next? Either way. Yeah. Okay.
I was just going to say, let's give Melanie a round of applause, right? Like, I mean, this is what the healthcare workforce is like in Hawaii: dedicated, caring, burnt out, exhausted. Will I survive 3 more years? I'm not going to answer for myself. I mean, I'm working unsalaried right now, so I think that exemplifies my commitment to surviving. I'm going to answer for rural healthcare and the canary in the coal mine perhaps being our facility. We may not survive 1 more month. So we missed, for the first time, we missed this payroll, and had to ask some of the physicians if they could wait an extra 3 or 4 days. They all graciously said, of course. And that's missing payroll without my being reimbursed, which I've I've committed to doing this for a year if it takes that long to change things. So the answer.
So what would you ask for? You get, is magic wand, it's gonna come true.
The
What
magic
would you ask
wand
for?
would be increased reimbursement through legislative change, through removing the GET tax, and through private insurers commercial insurers figuring out a way to increase their amount of the premiums that they spend on healthcare dollars.
Okay, great. We've got 2 minutes, okay?
Okay.
Because we want to put Stephanie on the hot seat a little
No,
bit,
no,
but
no,
if you
I'm
burn
not
into
gonna
her
let-
time, she's not
too
going to be able
close
to
me.
answer.
If something happens to her, that's going to affect me. All joking aside, my brother-in-law, who's a ophthalmologist, just retired. He's 64, but he always told me, he goes, you know, it's time to retire. And I'm talking only about my 60-year-old physician cohort, but it's time to retire when you have enough and you had enough. And I can tell you, there's a lot of people that are 60 that are getting close to having had enough. It's so difficult with the thing. So if they could alleviate some of the administrative burdens, the whole practice of medicine, so that you can get back to do what you love doing, which is
Practice medicine.
taking care of patients.
So back to the question though, you said
Yeah.
the problem. So what would make you practice 5 more years? The one thing if they changed.
Well, I
Because
think
now you're 65, you don't need the money as much.
I think my patients made me come back.
Patience, but how do we translate that to a solution?
The solution is finding the joy in practicing medicine.
Okay,
And it's different for everybody, and it's there because we all got into this for the same reason. But you find it and you will go forever
okay,
if you can afford it.
understood. So now I'm going to shift to our more hospital-based healthcare leaders. Les or Natasha, who wants to go?
Go ahead, Natasha.
I can, okay, sure.
Go
I can
ahead.
go.
Go ahead.
Sorry.
Go ahead.
Okay.
Natasha.
Question, do I see myself doing this in 3 more years? Yes, I hope so. So I practice and I'm administrative. With my practice hat on, I think clinical medicine is the most gratifying, beautiful thing that we do. We're all, we were trained and we have the privilege of supporting our patients and empowering our patients in their health.
But maybe I should shift the question just a little bit for you.
Yes.
What solution would you like to, in other words, you now have the ability to make a solution happen based on our conversations today.
Yep.
Which one do you think we should push forward?
Yeah.
And-
So, and maybe I'm going to answer with my administrative hat on, because that's, I think, a lot of the kind of thinking through macroscopically, what are solutions to keep us all going, right? To me, there are 2, and I don't think they're listed beautifully on the table, so I apologize. One is a theme that came up today, which is actually 2 themes that came up today. One is the growth of value-based models, the future of value-based models. We're all going there. I think a lot of times we equate value-based models with administrative burden because that's what it's looked like for us. The more value-based models are in, the more it means more staffing to support all of these things that are not direct patient care and checking boxes and forms. How do we partner with payers so that value-based models does not mean increased administrative burden? Because I don't think that they're the same thing, and I hope that they're not the same thing in our future. And I think we all want to be there. We all want to succeed in value-based models. We know that that's where we should be, but how do we have all of a seat at the table and advocate for that future not being just increased burden on an increased administrative burden?
But
yes.
choose, what are you choosing?
So I guess, again, not on the table, but probably partnering with payers to reduce administrative burden.
Got it.
My second part is investing in our teams. And I think we all know, we talked about team-based care a lot today, and addressing our physician shortage is really important, and our provider shortage is essential, but also addressing our healthcare workforce shortage is also essential.
Excellent. Thank you. Les, would you like to give us your insight? So you remember, I shifted the question a little bit. So I'm not asking you as someone practicing, I'm asking you wearing your healthcare leader hat, what would, based on our conversations today, and given that you could make it happen, what solution would you choose?
I would continue to transform our payment systems it's similar to what I mentioned earlier, to support our practices in different ways and to just transform reimbursement. That's number one. And as I opened with, I think as Natasha was saying, I think part of that transformation is supporting team-based care, that those models can work both in large health systems as well as in private practice. And I think some of the chat online is says, well, how am I supposed to, as a, as Melanie was saying, as a one person shop, provide those services? And I think with the right transformation of our payment system, that could be possible.
Okay, thank you. So I'm going to shift the questions just a little bit for you, Stephanie, because you're playing the insurer, right? So this is not about whether you're going to still be at HMSA. The question would then, I think, for you should be, you've sat and you've heard, and you can probably feel the pain of the providers that they're struggling. The canary is at 80% oxygen. If you could choose something that your role as a healthcare leader in an insurer that you could get behind and really, that you could get behind and that you think it would keep these guys in practice in the next 3 to 5 years, what would you choose?
So
Can I ask, are you speaking as staff or are you speaking as HMSA? I'd like.
I'm asking her as a healthcare leader representing HMSA. So I do want her to wear that, that hat. We know it's Stephanie, but I'm asking her to lean in from that vantage point.
So again, thank you for allowing me a seat at this table to be part of this conversation. I'm really interested in being part of the solution and having, this conversation, as painful as it can be, I think is really one of the most important steps to trying to move forward together, because you're right, we need to lean in together. So reducing administrative burden is the one that is kind of near and dear to my heart. I think a lot about, trying to create a healthcare experience that's worthy of our family and friends, while still trying to meet accessibility and affordability and all of the other things that are part of this delicate balance in our healthcare ecosystem. But returning the joy to the practice of medicine is something that I hope to really work on going forward. I realize that there are many, many opportunities for improvement in this area. And I hope that, we can have, open and honest conversation about how we can partner on doing this going forward.
No, thank you. Thank you. So we're hitting the end of our hour, and to summate, I would like everyone in the audience back to that original QR code to choose what you believe from based on your own opinion, as well as whether or not the panel has convinced you otherwise, what you think the priorities of solutions should be. What I heard today, I heard reimbursement, I heard decreasing the administrative burden, team-based care. I keep personally throwing in the rural differential pay, as well as entertaining the role of risk-based models. I'd like to thank our panel. I mean, it is no fun being up here. We had everybody in the hot seat, but I think they were wonderful. And if everyone could give them a round of applause, I would appreciate it. Particularly poor Stephanie, who has to represent insurance, but I think it was a really healthy conversation. I wasn't able to get to all the questions that are on, that you're streaming, but they will be collected and we'll get back to you. So keep adding them. I want to thank everybody. This is our community. We're all bright people. And the only way we're going to fix this is if we fix it together. Those are light words, but I think that's the reality of what we're in right now. I think everybody, whether you're a physician or an APRN or a PA, decided to go into medicine for reasons that I think we commonly understand. And the joy of medicine is being lost. And we need to find solutions that bring back that joy and allow us to stay and raise our children here in the state. But on that note, thank you everyone for your time. And I think Kelly's going to transition us to the next.
Thanks, guys.
Wind and mountain, caressing rain, passing on the silent melody, a lonely song without a voice, seeking after home. Wind and mountain, caressing rain, passing on a silent melody. Elua ka ua, ikitapa ho'okani, akahia, Hawai'i, hauma, alohi awale. Ekane o alani e, ekane o alani e. Aloha gaua, aloha gaua.
I think that one should go right there.
There are 4 live